Welcome to tonight's webinar, Understanding the Basics of Bulk Fill Composites. Indications for bulk fill composite. My name is Frank Milner. I'm a dentist in St. Paul, Minnesota. Next year is my 40th year of being a dentist. I've had a lot of clinical experience. I've had a lot of ups and downs and gone through phases, and tonight I'm excited to bring you a new dimension of dentistry, very popular, about bulk filling. And I know there's people from all over the world. Some of you can hear me, some of you can't. I'll do my best, but my goal is to give you a take-home message so you can bring it to your patients and have clinical success. Let's talk about disclosure. I am paid by Coltine to do this webinar, and I want to thank Viva Learning for hosting tonight's webinar. Tonight is my 10th webinar coming to you. And I want to say a special thanks to a dear friend of mine, Pam Conaway from Coltine, who is responsible for getting me involved with the Coltine company, who's very passionate about bringing continuing education. So Pam, this webinar is for you, and I hope to see you soon. What are the learning objectives tonight? Clinical indications for the bulk fill composites. Why are bulk fill composites gaining in popularity? How do they work? Do they work? And learning techniques to successfully and predictably place bulk fill composites. I like quotes. This is my quote. To find aesthetics, one must understand the principles of reverse engineering. In other words, see the tooth from the inside out and restore it accordingly. It's bottom-up dentistry for top-down aesthetics. It all starts at the epicenter of your adhesive layers, and how do you control the stresses, polymerization stress, shrinkage, volumetric changes, preventing sensitivity. It all starts from the inside out, and so does bulk filling. Van Gogh said, "I'm always doing what I can't do yet in order to learn how to do it." I'm a curious kind of guy, very creative, and when I find something that works, I understand it, I study it, and then I know how to use it to find clinical success and predictability. Well, let's talk about this now. Let's talk about the first bulk fill material I used in 1972 through 1976 at the University of Minnesota. It was called amalgam. It was inert, self-sealing. The only adhesion we had was copalite, a cavity varnish. Well, the material worked pretty well, but the preparations, the GB black preparations, destroyed tooth structure. But you know, bulk filling's not a new idea. I even was the first dentist to start using Adaptic and Concise. These were bulk fill composites that had no adhesion. The particles were real big, and it was hope dentistry. We hope it set up and stayed in the tooth. So bulk filling has been a concept that's been promoted for many years. Filling the preparations all at once instead of increments does make sense, since it saves time and makes the procedure easier. But is it adequate? Is it the same as? Is it better than placing and curing resin in increments? Some of the products that are now being promoted as bulk fill resins were placed on the market many years ago. Some of them were not promoted as bulk fill when they were first introduced, but now they're being represented as such. The bulk fill composite concept has come and gone a few times in the last several decades. So tonight we're going to explore it and see why it's gaining popularity. What is the difference between traditional and bulk fill composites? Everybody does direct dentistry, so we understand what we're doing. Traditional composite relies on increments of 2 millimeters for light carrying. And we limit the volume of the materials to limit the shrinkage and the shrinkage-induced stress that goes to our adhesive level. And if the contraction stresses are larger than the adhesive strength of the composite, then you get marginal gaps, you can get micro leakage, you can get secondary decay, you can get sensitivity issues. All these things are problematic. With traditional composites, you have the ability to select the proper shade and the opacity because you can visualize it. You can visualize the material as you place it. Where does it go? Can you get the light on it? And the bulk fill materials now, what are the differences? Let's talk about the manufacturer's claim that you can have greater depth of cure and lower the polymerization induced shrinkage stress. Well, these bulk fill composites are increasing in popularity because of the practitioners of the so-called bulk fill materials, which are claimed by the manufacturers to enable the restoration to be built up in 4 layers or layers of 4 millimeters at a time. This new material class includes flowables in higher viscosity pastes and material types. There currently exists a growing trend in the use of bulk fill materials amongst my fellow practitioners due to a more simplified procedure which translates into economics. However, the lack of available literature in the clinical performance promotes much in vitro research. I think we're lacking in the in vivo research, which ranks the properties of bulk fill materials relative to the conventional flowable and paste types that are already in the marketplace. So if you look at the bulk fills, they have greater depth of cure. They can be photocured in increments of 4 to 5 millimeters. Now that's a number we have to quantify and measure, because if we're over 5 millimeters, can we bulk fill if the curing lights can't get down that far? So the posterior composites and the new bulk fill materials, let's look at where I came from in the 1990s. 94% of the dentists chose amalgam as their primary intercoronal posterior restorative material. Now let's walk that up. Let's take it to 2010, and now the composite resin restorations had exceeded amalgam by a ratio of 2 to 1. And in fact, according to the research now in the literature, it's estimated that 1/3 of the dentists don't use amalgam. There's a steady decline, and there's reasons for that, as the literature shows. What are the reasons? Well, pretty obvious. The patients were desiring a non-metallic look. The mercury scare was out there. They wanted more natural looking anti-amalgam sentiments that were driving the trend line. And actually, this is where the spawn of minimally invasive adhesive revolution took place, because everything started in the 80s and it got better because everything was next generation after that. Well, the composites were less invasive than the amalgams. GB black was not necessary because of the adhesion properties. And as I've witnessed throughout the decades, the significant improvement of the composite resin material, gone from macrofills to hybrids to microfills to microhybrids to nanohybrids. Everything got better. Everything is becoming more chameleon-like. The physical properties are getting better. The durability, the water absorption, everything is really where it should be today. We're in the sweet spot. Now, factors with posterior composites and the bulk fills. Well, when we talk about the posterior composite predictability, we want to talk about post-op sensitivity, because the layering concepts of 2 millimeters can be problematic, as you have witnessed in your clinics, because of the lack of controlling the forces that go underneath and react with the curing light. And also matrices, what kind of contact are you achieving in the class 2s? Well, the bulk fills are faster placement, and they'll reduce the need for multiple layers when you're placing posterior composites, if it's predictable, if it translates into durability. Looking in the research in the papers in 1996, it's very interesting, because one of the first papers came out questioning whether the incremental filling technique reduced overall polymerization shrinkage stress. Well, this was in the literature in 1996, and they said, concluded that the technique actually increased shrinkage stress. Well, currently now today, we've kind of flip-flopped, and now the literature supports that layering in increments of 2 millimeters actually decreases the stress. So that even in the literature, that's come a long ways, as you can see from the references citing there. So my question is, why has it taken so long for the industry to recognize the flawed technique of incremental layering? We've kind of just marinated in this for decades, trying to figure this out with better adhesion, better physical properties, better lights, better matrices. We need to figure this out, and I think we can do part of that tonight. So what are the key properties of bulk fill composites today? Well, the bulk fill composites they have to possess some important characteristics. First of all, they have to have low polymerization shrinkage stress to decrease the micro leakage and counter polymerization shrinkage by reducing the stress and exhibiting some elasticity. Secondly, bulk fill composites should demonstrate an increased depth of cure at least to 4 millimeters, which is accomplished in part by being more translucent and a highly conductive light sensitivity to get the light down there, so these materials can be somewhat translucent. Third, they should be more flowable to allow for easy cavity adaptation, including in the cervical margins and existing boxes. And they should be easy to dispense with minimum handling. So these are unique, and also excellent wear and physical properties. They should be aesthetic and not overly translucent, so you can have a chameleon effect. And most importantly, I challenge the manufacturers to give us the data that match the specifications. And this shouldn't be anecdotal. This should be scientific and in vitro and in vivo itself. So let's go over some of the physical properties that we know and some of the guidelines and the parameters, the components of predictable aesthetics. What is the depth of cure? And the hardness test that we do is how deep can the light penetrate, assuming you're using a good curing light, and what is the surface like? How durable is the surface? How can it polish? Does it scratch? Volumetric shrinkage this only happens once after you light cure it, is the possibility of the material pulling away from the tooth surface during polymerization. We all know what this is. This is the key one right here, polymerization shrinkage stress, and this is the one we key in on, especially for bulk filling, because the restorative tooth interface, this is the interface of the adhesive seam to the tooth substrate, is constantly subjected to stress and strain imposed by polymerization shrinkage forces, thermal stimuli, and the functional occlusal load. So our bulk fills should really lower polymerization stress. The flexural strength and the modulus of the flexural modulus, is the indication, can the material tolerate occlusal load without fracturing? It determines how the material will handle the daily stresses associated with transient flexing, and if the material is rigid and does not deform significantly under occlusal load. Everything is getting better, and these new bulk fills, including the one from Philip from Coltine tonight, definitely fits the qualification for bulk filling. Fracture toughness and fracture work. Well, on terms that we don't talk about that much, it's the ability of the material to withstand fractures, especially in stress-bearing areas. However, it provides an indication of the materials to resist failure caused by propagation of a crack. Now, does that remind you of zirconia a little bit? It probably should, but this is true, the fracture work and fracture toughness. Water absorption and solubility. Of course, if you're imbibing water into the materials, you got volumetric instability and dimensional changes. That's not good. Radio opacity, you have to see it on the X-ray. So this is measured in terms of the aluminum correlation to this. These are the parameters that we do. Now, let's look at clinical report from Dr. Christensen. And what he found for bulk filling is basically it's related to the curing lights, because many dentists have worn out curing lights. They haven't been calibrated. They haven't been tested, and they don't deliver optimum energy in the spectrum of light to cure the material. And that, according to Dr. Christensen, the 3 to 5 second cure doesn't penetrate as deeply as the slower curing lights. And we're assuming that all curing lights meet a minimum standard of 1,000 milliwatts per centimeter squared. So Dr. Christensen is really cueing in on the light carrying capability and consistency of the photons, and also the volumetric depth of the box. According to Dr. Christensen, class 2 box can go from even down to 7 millimeters deep, and if you're curing to 5 millimeters, something's not getting cured. So we have to find a way for something to dual cure down there and or get the light down in a deep shaft. If you look at most lights that emit from the curing light, they don't emit at 90 degrees from the emission source. And so you're inefficient as you go into different anatomical areas, such as the lingual of anterior teeth, facial or lingual of posterior teeth, and the distal box, especially when you get into a distal extension box and you're chasing decay around the lingual side. You don't know where the light is. Can it get down there? Which begs the point of getting better curing lights. There's a lot of good curing lights in the marketplace today, but the point is make sure you're using a decent curing light that's being tested and clinically performs correctly. Now, if you look at Dr. Christensen on the follow-up on the backside of this, is that he says that bulk filling can be difficult in different situations. And his summation is he strongly feels that inadequate curing is the major reason for premature failure of class 2 resins. And this could be bulk filling as well. Let's look at the characteristics of an ideal bulk fill composite. I don't need to read them off to you verbatim, but these are some of the things we've been talking about, and it begs the point of dual cure capability to lower the stress. We want low micro leakage, low polymerization, shrinkage, and stress, good physical properties that behave like light cured composite. They have good surface polish and the wear is good, and good dispensing and confidence in the material. Let's go through a visualization. Which restorations would you restore with bulk fill and why? I thought this was worthy to kind of stage before we get in. If we look at a typical amalgam here, and when we start looking at the surrounding cusp structures, obviously when we do a class 1 amalgam on this one, we don't need bulk curing, dual cure. It's maybe on this one, on this second molar, but we have to start thinking what we're doing when we start creeping up into these weight-bearing areas here, and how the tooth distributes stress underneath, especially if this is hollowed out. And if you're going to be incrementally layering in here, sometimes you can get some stress. So this tooth could be a candidate for bulk filling. When we look at something like this, we've all seen it in our practices when we get these MOL buccal linguals and in your underneath cusps and everything. I'm going to ask you now, unless you're using glass ionomer, which is still used in my practice, this could be one for bulk fill dual cure, because you're going to have less stress in the box get some good contacts, this is a tooth that you'd probably want to use bulk filling for, especially dual cure. When we get into this taking apart business, especially in the bicuspid here where we have weak buccolingual cusp, well, we're not calling them composite restorations. These are actually core buildups, and you can use the bulk fills for core buildups, and you can use the dual cure bulk fill fill up from Coltine as a core buildup material. There's just too much potential stress, too much core weakness to leverage incremental layering in there, at least in my standards that I imply in my practice. When we look at this molar right here, again, by the time we get all this cleaned up and we get a spicule of enamel surrounding this, you can really lasso this with some composites, and pretty soon you're getting into some sensitivity issue. This is probably why I would use bulk fill, especially dual cure. I'd use glass ionomer, or even a sandwich technique in this clinical case right there. Well, once in a while it happens. We get these gold, beautiful gold inlays, onlays from the 70s and before, and darn it, we got to take them apart. And it kind of hurts me to do that, but I carefully take a micro burr and section that gold, take it out. And then these are going to be core buildups in here and possibly here that you want to use before you put your indirect restorations on there. What are some of the products on the market? Let's talk about one a lot of my colleagues use, and this is Sonic Fill from Kerr. For disclosure, I have not used this one myself, but I've heard a lot of good things, and their claim is you can bulk fill it up to 5 millimeters. And the Sonic handpiece here is about $850, and by vibrating the material, it changes the viscosity up to 80% to make it more flowable. It's a very interesting technique. I'm not here to criticize or endorse. I'm here to tell you that there are options in the marketplace as well. This is their schematic here about traditional bulk fill into different layers, and one layer for bulk filling for Sonic Fill. So this is how they manage their material with a different handpiece involved. Let's talk about composite shrinkage and sensitivity, and let's talk about giving some credit to Bisco and Dr. Suh. Most of the adhesion information I've learned throughout my career came from Bisco and Dr. Suh. These are not my slides. These belong to Bisco. I'm going to give them credit, and then I'm going to tell you that they also make bulk fill products too, Biscore and CoreFlow, and let's be fair and give somebody else some credit as well. Dr. Suh said to be a student of aesthetics, you better be a student of adhesion and know your chemistry, and how true this is today. No matter what you do and how you're going to do it, you keep it simple and you keep the dentin sealed, keep your cable surface margin sealed. This is by fastidious protocols of adhesion. Know your chemistry, know your generations, and that's what this segment's all about. Well, you know this as well as I do. For total etch or self etch, either we're wet bonding, and with wet bonding comes some sensitivity. How wet is the dentin? How dry is the dentin? How much rinse? How much dry? That sort of thing. Or with the self-adhesion, self-adhesives today, we have dry bonding without etching the dentin. We're actually have an acidic monomer that changes the pH to a neutral pH to cause resin tag formation, and we have less sensitivity. However, the caveat is we have poor enamel bonding according to the literature, unless you rotary braid the enamel and or use phosphoric acid, called selective etching, which is my protocol to do. So if you look at the bonding to dentin, either we're going to remove the smear layer and open up the dentinal tubes, 10 to 30,000 per square millimeter, which also invites hydraulic flow from the odontoblastic processes and could translate into Brandstrom's theory. Or we're going to keep the smear layer intact and collapse it and form our micromechanical retention that way. One is total etch and the other is self-etch. Etch and rinse, wet properties. The other one is no rinse. I am a subscriber to selective etch rotary abrasion of virgin enamel and using 7th and or 6th generation adhesion. So one way we can over-dry the dentin, collapse the collagen fibers, and then your bond strengths are very marginal and inadequate at best. Collapse collagen. In a perfect world, Douglas Terry, colleague of mine, said the tooth restorative interface looks something like this. You have your lateral resin tags, you have your hybrid layer, your adhesive resin, and your composite. In a perfect world, this is life at its best. Unfortunately, we know it doesn't work like that. So when we get into these larger preparations, like I showed you the clinical cases before, we really have to understand what are we getting into. And these are the C factors and the hydraulics of flow. These are about the stresses that go into there. What kind of modulus of elasticity are you using if it's a dentin-based product? What is the compressive strength for enamel types of materials? There's a lot of things you have to take into account. Well, by the time you get your adhesion in there and start incrementally layering and or bulk filling, you really have to understand that your dual cured materials deep down underneath, when you have inadequate foundations of tooth structure to support your restorations, it's either going to be glass ionomer in a sandwich technique, or I'm encouraging you to look at the dual cured composites in the marketplace. And self-care, dual care, where the light can't penetrate, that's what we're talking about, the bulk filling from Coltine called Philip, which we're going to get into. So one of the pitfalls, again, thank you, Dr. Sa and Bisco, for giving us this information, is that when you have a substrate of material, could be conventional light cured material, and you have your bonding adhesive in, and you have your light source. When you polymerize the material, you're going to get some volumetric shrinkage, maybe 57 microns. This is in the literature. This is what happens. Now, if you do the same schematic again, you have your bonded interface again. Doesn't make any difference which adhesion it is. You have uncured material. You light cure your material, you're still going to get the shrinkage at the top where the flow and the stress comes out, the isthmus of the class 1. But if you have poor adhesion techniques on your gingival seat, you can get up to 102 microns of liftoff. And here comes the hydraulics of flow. Here comes Bransford's theory. Here comes your tooth sensitivity issues. Unless you reduce the stress by using a glass ionomer or even a flowable liner, a Fuji liner, something like that to keep the stresses down. So if you look at the schematic of light cured versus dual cure self-cure, the evidence does support that you're going to have less stress, especially in your adhesion layer, by doing that. So this is how the tooth relieves stress when you cure it. The stress comes out the occlusal portion here, and the larger the volume is on the class 1, the more the stress can come out. Where we get in trouble on the C factors are the small class 1s, where you have a very small opening portal to release the stresses. The relaxation by flow, less stress. Now, let's continue on when we talk about the effects of shrinkage stress. Well, in the literature, we're going in deeper here. Let's talk about stress and strains of what happens according to the literature. How do we control this? If you look at this schematic right here, and whether it's self-cured or light-cured, which one has less stress and which has more stress. If you look at a light-cured substrate, you have more contractual stress, more shrinkage stress, more volumetric changes. When you look at self-cure, dual cure in here, you can see that the stress is less. I'm making a point. Less stress. And how fast do you cure? Are you using a ramp starting? What kind of light are you doing? What kind of energy are you doing? Where's the light guide pointing? Do you have a turbo tip? All these things come into play. So if you look at a paper in 2000 by Dr. Saw about light cure, dual cure, and self-cure, and what is the difference in the strain and shrinkage, it kind of says it here again, is that you're going to have less stress with a self-cure, dual cure material than you are potentially with a light cure, according to the clinical indication. Again, the volume of clinical cases we do are going to be generalized incremental layering. However, when you cross the line where you have to get into managing stresses, then you're going to look at a self-cure or dual cure materials to help you reduce the sensitivity issues, 45% less, in fact. So how can we be sure our light cure bulk fills get to the cavity floors? Well, here we go. That's why we're talking about dual cure materials. If you look at some of the wonderful products that are on the marketplace, I'm familiar with these, and these are all good materials. I would never say anything untoward another manufacturer. And I can't tell you I've tried all of these products. I certainly have tried Philip. I've tried Extra Fill. I've tried Tektronix Evo Ceram Bulk Fill. I have not tried Sonic Fill. I am familiar with Hyperfill by Parkel, and it's kind of an interesting product because it's very inexpensive. It could be $6 a milliliter, comes in 2 different shades, A1, B1, A2, B2, but the expense is a selling product from Hyperfill. Also, the dual cure other bulk fills I'll mention that I'm familiar with that I think are good performers are Zircules from Clinician's Choice. Again, I'll mention Biscor and Core Flow from Bisco. Those are good products as well. And now we're coming to tonight's product, feature product, which I'm excited to bring it to you today. I think you're going to hear very good things about this into our scientific journals. And this is the bulk fill dual cure material Philip by Coltine. And it's interesting, by Clinicians Report, a recent survey of 786 dentists indicated that 49% see a need for dual cure restorative resin for class 1s and class 2s, and in areas where the dual cure would be most desirable or the deep preparations. Most products are highly light cure in the bulk fills are highly light cured, but then you're going to have a highly translucent material on a lot of them, especially the flowables, because you can't have a lot of opaque particles to mimic tooth structure because the light's got to get down deep into the material itself. So Philip is a dual cure medium viscosity material. It's the newest generation. Certainly there's going to be more to come. The advantage of resin-based composites with a simplified and time-efficient handling is less stress, and then it can be administered in any depth of the filling without additional covering. You don't need a sandwich on it. It behaves almost like their Synergy D6. So it's a very good material. And if you look at the hallmarks, it's going to be for class 1s, class 2s. We've talked about this. And you're able to fill the whole preparation in one fell swoop. And it's going to be, it takes 5 seconds of light curing, so you can start using rotary abrasion. You can finish this in 1 minute. It really has a lot of good qualities. The cost on this one is about $18 a gram. In the marketplace, as I know it, the competitors are anywhere from $21 to $29 a gram. So it does have some competitive features to it as well. The working time is 1 minute when you introduce the material out of the cannula. The set time, complete cure time, is 2 minutes. And like I say, once you put the light on the surface, you can start doing rotary finishing in 5 seconds. For those who are still using amalgam, it's a good amalgam replacement because it is a bulk fill material. It's medium viscosity. It's not too runny. I find the handling is very good. It's fluorescent. It's opaque. It actually is tooth colored. We'll talk about the colors of this versus a traditional bulk fill that might be more translucent. But another one that I commend Colting for is the bioactivity, because as you know, glass ionomers have the ionic exchange adhesion, calcium, the phosphate, and fluoride. This has zinc oxide, which is bioactive, which reduces the proliferation of bacteria on the restoration. So this is bioactive, gaining popularity, a term that we're all becoming much more comfortable. Again, $18 a gram. Now, with the bulk fill dual cure, you use the Parabond here. They have their own A and B liquid that you mix together. It has a dual cure activator in it. Now, as you know, with incremental layering, if you overestimate your material and start getting shrinkage stress, volumetric changes, and then you're going to get into stress. Well, with the Parabond and the fill-up, the epicenter is in the center of the tooth, taking the stress off the tooth restorative interface, which decreases the polymerization shrinkage stress of the material according to manufacturer's specification. I don't do these data tests. I have used fill-up since it's been introduced into the marketplace and before, and I have not encountered tooth sensitivity. One of the hallmarks too that I think that Colting should be very proud with this material is the marginal adaptation, is that it has, according to criteria in the bar graphs here, it performs very good in the marginal adaptation with diminished micro leakage, staining, water absorptions, things like this. Because if you have a high adaptation, your preparations are sealed, your margins are sealed. If you have a low adaptation, your margins can percolate and get micro leakage. Fill-up has less photoinitiators than a lot of the other products in the marketplace. There's less stress, there's less translucency than other manufacturers, and since you have more opacity, you have less light penetration that is needed, like some of the others going down to 4 or 5 millimeters. That means you can maintain the Vita characteristics of the opacity, and you have less internal stress of the tooth. The surface roughness, when you talk about that, I think this is very interesting, because the harder the surface, the harder it is to polish, but once you get it polished, it stays polished. And if you look at the gloss and how the performance is with the fill-up here, the surface after polishing performs very well. In fact, it performs as well as their Synergy D6. This is a nanotechnology, nano hybrid of material, which most materials are today. When you look at the way that fill-up is dispensed, it comes as a universal shade. And as you dispense it out the cannula, it appears to be a Vita A1. But after chemical curing, it goes through a visual change, and you basically carry it. It basically comes up as an A2, A3. In the posterior, you know that as well as I do that most of your category shades are in the A2, A3 range, which is indicative of dentin in that area of the tooth. So I think they got this right. The working time is 1 minute. In other words, when you have a large volume of material, you can't be putzing around with this. You want to get the cannula into the box, start expressing the material. At no time do you take the cannula out of the material. I keep on squeezing the material out, keeping the cannula under the material, and that way you can just kind of swirl it around, watch it work. You get about 1 minute, so you got to be on it, and you got to be working and visualizing what you do. Light curate set time 2 minutes. Who can argue with that? Now, let's talk about a clinical case and what we do. This is one I did. If you look at this clinical case, no different than what we've looked at before, is that when you have a class 2 here that's washed out, this is probably, I'm guessing, heck, this could be a material from the 90s, could have been late 80s, something like this, where you have the attrition erosion. And by the time that you get this preparation opened up right here, according to Graham Milicic, Tim Rainey, and others in New Zealand, Australia, you have the peripheral enamel rim. You can't distribute stress into the dentin, which distributes it into the long axis vertically down the root. The stresses are going to accumulate right here, and this is where you start getting these compression fractures on the crowns, on these cusps right here. So this is prime time for either glass ionomer with a sandwich technique as a interim restoration core buildup, or you could go into a self-care material. And if you've learned tonight that dual care capabilities are your friend, then you certainly could do a fill-up restoration as a transitional restoration. If you're looking at the survival rate of a nerve, if you've got deep decay, you've got to go down there and put some calcium hydroxide or whatever you want to place over the pulp to see if it survives. So this is what I would do: use it for a core buildup, survival of the nerve, the vitality of the nerve, and then transition into full crown or onlay coverage, which would probably be my favorite selection today. Well, by the time you take the material out of the tooth, you don't have a whole lot left. And back in the 70s, we would have done Peter K. Thomas anatomy, put some Coltine whale dent pins. Thank you, Coltine, 4 of them at least. Hopefully don't go outside the root, and hopefully don't penetrate into the pulp chamber. Put some Copalite in there and just keep on mixing. But this is different. This is a different time. This is a different era, and we can manage these stresses. The matrix band here is an Omni band from Ultradent. You can use Garrison bands. There's a lot of good ones out here, Triodent. But I like the Ultradent Omni bands. Are disposable. They come in Mylar. They come in dead soft, amalgam, distal extension, pedo, and at least with a Mylar band, you can get the light in there. Again, there's other good ones as well. We would do, according to the criteria here, it is a total etch technique. I would probably put Conceptus in first as the first liquid introduced, rinse, and manage the tooth that way, doing a total etch technique. Rinse and dry. Again, dentin shouldn't be totally dry. It should be damp. So if you over dry, I would re-wet with a cotton pellet with a little bit of water, any of the re-wetting agents that you want. This is the Parabond now. This is Parabond A and B. You mix them fresh. Under no conditions do you open up these caps until you actively are placing the material, because otherwise you lose your chemistry and the volatility of these adhesives. You mix it, you mix them together, you massage it in for 30 seconds, and then you lightly air dry. And when I say that, there's no universal standard. The dentist should do this, not the assistant, because when you blow with a vortex of air, a high velocity, where does your adhesion go? Does it stay? So a very light air stream to just let the chemistry work, and do not light cure at this point. And then what you do is take the cannula and just start at the gingival box, go back and forth, keep the cannula under the composite material, and don't take it out. You may introduce air voids, go back and forth, back and forth. Actually, I'm not trying to be funny about this, but this is my sonic fill by moving my hand around here with the cannula of the material. You get 1 minute to do this. It's pretty easy. You could take a cotton swab, cotton pellet, and kind of pull it around as you wish, or any of the instruments you want before you light cure it. Light cure for 5-10 seconds. Heck, there's no harm in doing a little bit trans enamel polymerization from the buccal, the lingual. I'm not one to rush into these things. I let the set time go to 2 minutes, and then I just do a nice job on the rotary, finishing down and polishing with the materials of choice, albeit Coltine or others, whether there's clinician's choice. Schofel makes good ones, Alternate makes good ones as well. But that's what it is, a wonderful transitional interim material to see how the tooth performs before you find what is your next generation of material. So if you look at where we're going in our conclusions, we've covered a lot of ground. I've tried to be evidence-based. I try to be factual. I try to be fair. And I want you to incorporate dual cure bulk fill materials. Now, if you're a sonic fill or you use hyperfill, so be it. But if you're on the fence and you're trying to decide how to enter into the marketplace, there's a place for the bulk fills today. Understand the limitations, understand the clinical indications, and I have given you one example of a dual cure, not light cure, dual cure bulk fill material. Don't fly blind. There are inaccuracies. There are pitfalls with anything, whether it's incremental layering. There are pitfalls of amalgam. We know this. Anything we do, the more we can decipher our clinical abilities and do things to the best of our ability, the more predictable protocols we're going to get, the less calls we're going to get on sensitivity issues. We'll feel better about it. Be case specific. Choose the right product for the right case. Don't fly blind. One size does not fit all. Be analytical. Take a step back before you go forward and say, what would be the best solution for this clinical case, whether it's glass ionomer, whether it's traditional incremental layering, whether it's sonic fill, whether it's hyperfill, whether it's extra base. You be the judge and include in your decision tree fill up from Coltine today. Now, Plato, as you know, was a pretty good philosopher, and he said a good decision is based on knowledge and not by the numbers. Don't look at the data. Look at everything. Look at the in vitro, in vivo testing as evidence, and don't be encouraged by manufacturers' bar graphs that could be their marketing to lead you to a clinical decision. Read the reports, whether it's Dr. Christensen's or any of the literature in our dental textbooks. Read that and go from there. And remember that defined aesthetics is true. I have learned this the hard way. I was a top-down guy, and I thought everything was from the top down. I was sadly mistaken. In the AACD as a board examiner, when people go through accreditation and show me their cases, of course, the surfaces look good, porcelain, composite. I'm more curious to see what were your preparation guidelines. What generation of adhesion did you use? How did you prevent sensitivity? How did you prevent micro leakage? How did you perform down there in the adhesion layer before you got to the top layer, and that will tell me if you are astute in your quest for excellence